Hello, good afternoon, ladies and gentlemen, and welcome to this panel on science, not fiction, how digital technologies can change the course of cancer care. I'm Shuli Ghosh. I'm delighted to be moderating this session. It's lovely to see so many of you in the audience. Rather fittingly, some of our audience are joining us virtually online, and some of our panelists are also joining us online. The COVID pandemic has had a huge impact on cancer care across the globe. We've seen cancelled routine screenings, disrupted treatment, delays in diagnosis, and we now have a huge backlog of patients to see. The knock-on effects are going to be felt for quite some time, and we're really only just beginning to grasp the ramifications of what that means. So the question is, how do we respond to that as a global community, and how do we close the gaps? And this is where digital technologies and health data are going to be even more critical. So during the pandemic, of course, we saw an extraordinary acceleration in digital innovation and in the take-up of digital technology, things like data tracking apps to the mainstreaming of online consultations. And digital innovation also promises to improve future cancer care in terms of bettering our understanding of the disease and changing the way that we interact with healthcare professionals. But countries, of course, are at different stages of digitization. There are challenges in how accessible this kind of technology is. So today we're going to be discussing what digital technology means for cancer care around the world and how can we make it available for all patients. My speakers today, they are a great panel. They are from the public and private sector, experts in their field. So let me introduce them to you. Coming to us virtually is Dr. Svetlana Axelrod, Director of the WHO Global NCD Platform. Previously, she served as the WHO Assistant Director General for Non-Communicable Diseases and Mental Health, leading the WHO's work on NCDs, their risk factors and mental health conditions. The three lovely gentlemen to my right, we have Professor Frederick Chite-Asiwa, the CEO of International Cancer Institute, an organization whose main purpose is to expand education, clinical care, and training opportunities in cancer control and research across sub-Saharan Africa through multi-sectoral collaborations and partnerships. In the middle, we have Dr. Sanjeev Arora, the director and founder of Project ECHO, a distinguished and Regents Professor of Medicine with tenure in the Department of Internal Medicine at University of New Mexico Health Sciences Center. And he developed the ECHO model as a way to improve capacity and access to specialty care for rural and underserved populations. Michael Oberreiter is the head of global access at Roche. Over the past 30 years, he's focused on health economics and driving change for health systems development. And on our screen there, you can see Ray Pinto, Director of Policy for Digital Europe, the leading digital technology industry association, representing over 35,000 digital companies across Europe. Now, we're going to be speaking with the speakers over the next 90 minutes, but towards the end of the session, there will be an opportunity for questions. So we have questions coming into us online virtually, and that is simple as typing in your question into the Q&A box, and you can do that anytime. Here in the audience, I'll be inviting questions from you guys sitting there. You will see that there are microphones located on the steps there. If you're not close enough in those sort of first couple of rows, and I can see that most of you aren't, then you will have to go to the microphone to ask your question, and then everybody, including people joining us online, can hear it. So let us kick off. I'm going to start with Dr. Axelrod. Can you tell us, first of all, just set the stage, what has been the impact of the coronavirus pandemic on the state of cancer care globally?
Thank you, Shule. I hope you can hear me. And greetings from Geneva with very nice weather. I'm very pity that I couldn't join you in person today, but I think it's also a purpose of our digital health discussion today. So I'm connecting with you digitally from Geneva, from Switzerland, from the headquarters of the WHO. And thank you very much, Shuli, for introducing myself. I'm a director of the Global NCD platform, a department which is in the headquarters in Geneva. So I would like to say that today we are in a very interesting discussion, and I'm very happy to see the panelists who are attending us today, and we are going to discuss a very important issues about the cervical health, about the NCDs, and about the challenges and key opportunities. Let me go to my first slide. I just want to say a couple of words using the presentation. I hope it is going on with my technologies. I'm trying to move. They told me that it will take a couple of seconds.
This is the magic of digital tech.
Yeah. Yes,
Here we go.
done. So, as you know, colleagues, and the COVID pandemic was really dramatically affected into our lives. And these 2 years changed our lives. And we are really in this now situation that we have to think a little bit different how it was before. But NCDs, that is the problem was before, and it will be with us for a long time. And we know it very well. A lot of people have this kind of NCDs, these non-communicable diseases that we say. We have this chronic disease. Our very own and our lovers are suffering from NCDs. And this pandemic showed that it is very important to focus how we can live with NCDs through the pandemic. And these 2 years showed us particularly what is the challenges on the health systems and how they can bring it to the economies. And of course, the disruption have been seen across all health services, of course, including the NCDs, the mental health, and especially with the people who are suffering from the cancer. To stimulate our discussion, I would like to show you that the most burden of NCDs is the biggest killer in the world. And you can see on this slide that more than 14 million people are die from the NCDs, and especially from the cancer. We have the more than 19 million cases per year. And it is also mostly in the low and middle income countries. Let me go to another slide and to say, today we are speaking about the digital health, but let's see, what is the digital health? Is it? What is the definitions? How we understand the digital health? And I would like to present you on this slide how we understand the digital health. And I think it will be very helpful for audience and for all of us to see how we understand. And it is the e-health, the telemedicine, telehealth monitoring, and digital health therapy. This is the different steps of understanding what is the digital health is it. And that is very important for us from the very beginning to understand these definitions. I hope that today during the discussion, our panelists will focus on these different digital health technology that we are speaking of. And I think they will address their inputs on each of these definitions. I will just want to say that in the context of the COVID pandemic, the telemedicine is particularly the most important, where we can see the significant role globally. And my final slide at the beginning of this intervention will be focused on the survey that we've done under the WHO. This slide comes from the WHO National Online Survey that we did for the countries during the January and March 2021. And this survey was conducted and covered the most of the countries, more than 131 countries, that is the members of the WHO. And you can see that this is very important. The most of the countries had disruptions during the pandemic, especially on NCDs. So it is very important how our discussion will go on through this very important intervention that we have today. And as you could see, all the countries, rich or poor, reported about the some degree of interruptions in the community of healthcare on NCDs. Both cancer screening or treatment were affected. And this concern began because of the means of delay of care. That is very important to underline. The survey also relevant that the underlying causes of disruptions, such as the lack of transportation, insufficient of the PPE, shortage of medical personnel, or unavailability is very important. And it's mostly coming in the low and middle income countries. So I think it is very important that today our discussion will be focused on how we can support countries in their efforts, how WHO can support, and also what is the other stakeholders who could help us to involve in the support of the people that have the NCDs and especially the cancer. Over to you.
Some great points there, Svetlana. Thank you very much indeed. And the figures there that you're showing are really quite dire when it comes to the impact on cancer care. Let's try and narrow down that picture and look at it from a healthcare provider's point of view. Chiti, if I can start with you, the picture in sub-Saharan Africa has been particularly bad during the COVID pandemic. What kind of delays have your patients seen?
Yeah, thank you so much. So from our center, I am at International Cancer Institute, and we work very closely with government hospitals and centers around sub-Saharan Africa. We have about 15 various clinics in Kenya. And from our own clinics, one thing we noticed is that diagnostics, there was already a diagnostic delay, even without COVID. We had started some programs where we do opportunistic screenings, and we go to communities where we have barazas, we have various, even in churches, in schools, where we do a lot of screenings for breast, cervix, as well as prostate cancer. We couldn't do that because the gatherings were not allowed at the time. And so we had to actually pivot and start doing facility-based screenings and improving the facility-based screenings and routine screenings in various of those clinics. Then there was the issue where we do mentorship support for treatments in those centers. You know, we have very few oncologists, and yet we have so many patients to be seen. And therefore, as part of our program, we have an outreach program where we send oncologists and various healthcare professionals to various clinics around the country. Unfortunately, because of travel bans and restrictions from various counties to counties, we could not do that. And so we are improving this using teleclinics as part of that. And obviously, we were doing a lot of learning along the way. Then we had started a lot of tumor boards in each of these centers. We believe in multidisciplinary care for cancer patients. That was actually also interrupted because a lot of these centers believe and were used to face-to-face kind of multidisciplinary meetings. We started increasing our virtual tumor boards. So I would say this, before COVID, virtual tumor boards, we do them twice a week. We used to have about 20 or 30 people attend. Right now, we are getting over 1,000 clinicians attending these virtual tumor boards because of COVID, because most of them cannot really find a center where they can meet face-to-face just because there are still a lot of restrictions in several areas. So I can say we can look at it from the patient standpoint. There are patients who are getting their treatments in various places. If you look at Kenya, for instance, a lot of the radiotherapy units are actually in Nairobi. And we have a lot of patients who come from various different counties that were already undergoing radiotherapy and had to travel. Unfortunately, a lot of those patients could not travel due to curfew and restrictions that are imposed. So we had to really organize and coordinate a lot of these services. We got a lot of navigators to ensure these patients are taken care of. It was a little bit labor intensive, and some of the patients still missed their care. for those who are doing like chemotherapy, for instance, we could actually talk to the doctors from various centers and do those chemos in the centers where the patients are without having to move. So I must say that COVID, there were so many disruptions associated with COVID, but there are so many learnings and lessons that we got from COVID that we plan to actually carry on even as COVID wanes, hopefully, and even into the future. And some of it includes the digital kind of things that we are using, including digital pathology, that have actually really improved in terms of turnaround times for diagnostics in some of those centers that do not really have adequate pathology facilities. So we look at it as a double-edged sword.
Yeah, it's interesting how things adapt and how we can learn from adversity. Sanjeev, I know Project Echo specifically aims to reach rural and underserved populations. So just give us a quick picture of how the pandemic's impacted on your work.
Yeah, so ECHO is a way to democratize expert knowledge, and it's been present for about 18 years. In 2019, ECHO was present in about it's a hub and spoke model where experts mentor primary care clinicians, and we were in sort of 500 hubs connected to about 100 countries. But in COVID-19, what happened was that we had this global mentoring network already set up. It was set up for 70 different disease areas. We had 90 hubs for cancer and running about 150 programs. But as soon as COVID-19 came, a lot of our networks, whether they were for diabetes or HIV or hepatitis C, all pivoted to COVID-19. And we currently have had 1.3 million learners in 180 countries, which are being mentored on different aspects of COVID-19, all the way from prevention to vaccination to treatment. And this became the predominant mode. Currently, we are doing a lot of work on vaccine hesitancy, and specifically related to Svetlana's slide. So much has been left behind in terms of care of patients with other chronic non-communicable diseases. A lot of our work is currently on how do we get cancer screenings back on track? How do we get tuberculosis management back on track? Because so many of these other healthcare problems got ignored, and ECHO is focusing a lot of its effort there.
Okay, well, let's talk specifics then. Let's talk about how digital technologies can help in clinical care, because we need to close these gaps. Let me bring Ray Pinto in. So Ray, what have you been seeing and hearing from Digital Europe's member companies? And what kind of digital solutions are helping to make a difference right now as this pandemic goes on?
Thank you very much. I think we have to see, as we saw in the first slide, what are the technologies that are helping with the pandemic, and then more to the topic of what we're seeing in regards to the non-communicable diseases such as cancer. What can the technologies do? So, there's a couple of clear areas that I think we can see some immediate benefits. The first really is to ensure that there is more early diagnosis and treatment. And I hope we'll talk later on on this panel. There's a lot to say in regards to data and how that can be procured and processed and exploited to drive, the use of AI, for example, that can be used to help with the doctors to find with patients to early diagnose and treat cancer. We also, I think what is really important as well is that there's this shocking statistic that was shared with me that 25% of Africans believe that cancer has no cure. When, we now know today that the early detection of cancer actually allows patients to pretty much live a very full life. So how can we make sure that the education is needed so that people are getting care and know what has to be done? Unfortunately, another sad statistic is that 80% of breast cancer patients are usually diagnosed at the late to end stage, and this is where these technologies can really come into play. We can also talk about how the technologies, most importantly, I think, is not only lower the administrative burden that you see. So there's in many countries in Europe, hospitals were able to do triage far more effectively using chatbots, for example, where patients can easily, find out, do they need to go to the hospital? Can they treat themselves at home? What do they need to do? And that, gives the healthcare workers a lot more time to spend on patients, and that's important. And the other more important thing, of course, is to lower costs. If you look at clinical trials, the cost and the time of clinical trials can be greatly reduced through these technologies. And then, we heard, of course, about remote monitoring, which can play an important role. The last point I'd like to just give where these technologies can play an important role. And I've been listening very carefully to many of the panels today to the World Health Organization. And I was quite stunned that the overall view is that many governments are pretty much operating in the dark. Even in the many developed countries in Europe, Germany, for example, pre-COVID, it was pretty much impossible, and I guess still is today, to track who has been vaccinated. With COVID, we're getting a little bit more data better, so that's important. But when you look at global data, 85% of COVID cases are not even being detected. And you also see that when it comes to data, not the right data is being shared, one, and that has to change, and we can talk about that later. But also that when the data is actually provided, it is usually incomplete. And 7 out of 10 deaths around the world, when reported, has no cause registered to it. So you don't know what's causing these deaths globally, and it's very hard to do research and to find treatment and solutions.
But just a quick supplemental question to you, Ray, just so that we all know what kind of technologies we're talking about. You mentioned chat boxes there, and chat boxes are one of the big things which a lot of people have taken up so that they can talk to experts, nurses, what have you, and put in questions online and get answers. What are the kind of things are we looking at? Are we looking at, is it all artificial intelligence? Because some things seem quite advanced, and other things are things which we all have on our smartphones.
So, well, when you look at the technology, you got to look at what are the technologies that are accessible to the patients. And that's going to differ from country to country and region to region. A chat box, for example, may not be instituted in many countries in the world, right. Not because they're difficult or expensive, because they're not. They're super easy to do. But the culture of the populations to use them is not there. In Denmark, a chat box, using a chat box is a normal thing, right? It's just like turning on a light switch. You're used to it. You trust the technology. There's a lot of trust with the government. So, when they produce something like that, people want to engage with it. In other areas, one, trust is not there, and two, the culture is not there. So, but when you look across the planet, no matter how rich or poor, people have 1 or 2 telephones, and most of those telephones have the power of rooms full of computers. So, anyone on this planet pretty much, except of course there are some areas that have no technology, electricity, or anything at all, and that is a fact. But many of these countries do have the access at least to a device that can provide information through some form of internet.
Okay, and I know we're going to talk much more about accessibility a little later on, but that's really interesting about some of the applications that are available for patients if they can get to it. And Michael, let me bring you in, because private sector, of course, is heavily involved in R&D and digital innovation. How are companies like Roche leveraging these kind of technologies to develop new patient solutions?
Thank you, Julie. So let me build on what you said and what Ray said, where we said like every one of us has a smartphone. So we learned that digital health can be either the big leveler or it can be the big divider. So it can actually amplify existing inequalities in the system. An example where it definitely has amplified or was super useful is clinical trials. So when COVID started, there was a moment in time when almost all big clinical trial programs did stop for a second. Patients were afraid, patients did not show up, doctors were just had other things to do, so busy. So we could manage together with partners to really implement and switch completely to a virtual clinical trial program where patients would receive the care and could participate in the clinical trial from their homes. So care was delivered to their home. But we also learned, even in developed countries, and I give you one example. My mom is an Austrian. She's a chronic patient. When the Austrian system switched on to you could do virtually doctor's appointment, I'm not going to say the company, but my mom has a very old phone. It's a phone where I can play a game with a snake. So this beautiful app where you could register online around it did not work for her. And it took her literally months and she did not show up at the doctor because she did not get the information. So we learned it in both ways. And like what we are concretely doing as Roche, like we are investing in 3 areas. One is about using technology to improve the patient experience, which would mean how can you improve patient outcomes. Second area is really around, when it comes to what I just mentioned, clinical trial, how can you make research and development more efficient? How can you accelerate pathology? How can you better use data? And the third area is really around what we call augmented products. This is like, how can digital or digital health be used sort of like to accompany the clinical care, particularly in cancer. But the key important thing here is, and I stopped, is really like that we look at it from the end user perspective, whatever we're developing in that space.
Right. Yeah, my mum has got a phone even older than that. It doesn't even have the snake game on it. Let me bring in Svetlana again, because you said something interesting at the beginning, Svetlana. You said that telemedicine was the most commonly, or is the most commonly used technology. So just tell us a little bit more about that. How is it being used? Where is it being used?
Actually, coming back, and I think our discussion is coming more interactive. Really, what is the most important part is how the countries use the telemedicine. And as I said at the beginning, there are different definitions how we understand what is the telemedicine is. Our surveys show that half of our member states use the telemedicine to replace in-person consultations. And what does it mean? That it was to support the scheduling of medical appointments, the primary healthcare indication, the pharmaceuticals refills. But what was important, mentioned by the previous speakers in the panel, that it depends on the country. And it is very important. As the WHO, for us, is very important that everybody will be equal for the technical health technologies. And that is why we should produce these kind of tools that could be used by most of the countries in the world. And that is the last speaker told us that is very important that we will provide some kind of educational trainings and tools for the patients who are suffering from the NCDs. That is why we are working very closely with the people living with NCDs, with the civil society. We involve these different stakeholders, and especially the private sector, who could provide these new technologies that could be accessible to the people living with NCDs who are suffering from the cancer, who are suffering from non-communicable disease. And this is the case where we have focused our new guidelines and new tools from the perspective of the WHO.
Svetlana, thank you. And we've been talking about how so many people have, phones, 1 or 2 phones everywhere in the world. Chite, what is the situation in sub-Saharan Africa? Are patients able to use this kind of digital innovations, and what kind of applications have you found most helpful for patients?
Yeah, thank you so much for that question. And I really like what the other speakers have said. And even in sub-Saharan Africa, it's not homogeneous. There is heterogeneity in terms of not only the smartphones that are available. Like in Kenya, the penetration of cell phones is almost 90-95%. So it just means that any patient in any part of the country has an access to a phone phone. And even actually recently, we have co-developed an app that can be able to be used in terms of follow-up for HPV screening in the community. We are piloting it at the moment, which just shows there is quite a number of patients that can access this. However, as you move away and further away into the rural communities, we got this challenge where most people could not access. So if you want to do, for instance, a teleclinic, you are not really able to reach this person because as much as they have a phone, they can get your SMS messages, but they cannot necessarily get your videos that you are showing. And so for some of those centers, you have to be very creative in the sense that you have to look at almost like a hub and spoke. Where is the clinic that is closest to them, where you can actually interact with them? And so several patients are going to one center where you can be able to pass the information. The other things that we've seen is that we've been working on a model of digital pathology in various county clinics. But even when you look at some of them, they have differences in terms of infrastructure, when there is something to be the troubleshooting, whether they have a pathologist or not. And therefore, for each of these things, we have to actually tailor make it to the specific areas within Sub-Saharan Africa. But I can tell you for sure that I was actually amazed to note that the uptake of these digital platforms in Sub-Saharan Africa is much higher than I thought it would be. And I think COVID has contributed to that, but I also think the content of which you are actually giving encourages a lot more people to hook themselves onto this.
Yeah, it's because it's not just about having the phone, is
Exactly.
it? You have to have the network that operates the phone. And Sanjeev, would you agree with that? What kind of innovations have you seen develop through the pandemic, which are particularly helpful?
Yeah, I think that as you've heard, telemedicine is one thing where you're using technology to get to a patient. And that has been very widely used in developed nations. Hasn't been quite as effective in countries of lower income or even middle income, where although internet extends quite widely, it's not enough bandwidth at home in the last mile. Even the United States, we get into that kind of difficulty. So the approach taken by ECHO is a completely different one, and that is a workforce training approach. So what is happening, for example, in COVID-19 and in cancer care, there's a lot of new information coming out every single day. And so the challenge, of course, is how does a primary care clinician, a nurse, a community health worker have access to this latest information today? So what we took the approach is, can we democratize expert knowledge that typically resides in a university or in a large hospital, and it has a very difficult time getting to the last mile of healthcare? So we said, what if we took large numbers of primary care clinicians, let's say 30, 40 of them, and created a community of practice where each of them would get together once a week and talk about the problems that they're having in their practices. And through case-based learning, we would mentor them in exactly the same way they trained during their residencies, and gradually make them experts to achieve what we call force multiplication. The biggest challenge that I see in low and middle income countries in the world isn't the fact that you need technology alone to get a doctor to a patient. There are just not enough doctors. There are not enough nurses. So we've taken the approach, can we upskill a workforce? Can we upskill a nurse to be as competent as a doctor through regular mentoring? You know, when I did my residency program in gastroenterology in Boston, I would see a patient present to my professor. I would see another one present to my professor. And 2 years later, they started calling me a gastroenterologist. So I said, aha, I'm going to create new cancer screening experts in this country. And I'm going to do it by creating these communities of practice. They'll present cases and we'll discuss them, and we will empower them to deliver the care to their communities, which normally wouldn't be at all accessible to these patients. And we call this idea force multiplication. And we have a goal at ECHO to improve the health of 1 billion people by the year 2025. And we plan to do that through this workforce training and mentoring model to empower people, specifically also in the cancer field, where there are such massive disparities. Our audience may not be aware that a child in Africa has only a 30% chance of surviving cancer, the same child in the United States will survive 80% of the time. And it's not because they don't have $1 million medicine. Workforce training of doctors and nurses to provide care in those communities to their local patients can change that, and that's what we're trying to do.
Yeah, that's really, really interesting. Thank you. And when we talk about access, Chite, we were talking to you earlier about it. It's not just who has a phone, but where they're able to use the phone. They might not be able to get videos. There's also an issue about training. You know, the greatest technology in the world might be available. If they don't know about it and they don't know how to use it, they're not going to be able to access it. And we heard from Ray earlier about how it requires leadership. You need a government to produce these things and direct people, drive people towards them. So what's your view in how easy it is for people in low and middle income countries to access this kind of technology?
So you've actually brought out something that is very, very important. And one of the things that people always talk about when we are talking about capacity building, they always stop at after training. There is no mentorship or support or follow-up or leadership that galvanizes these people that have been trained. About 10 or so years ago, I would train a nurse, a general nurse, and say, hey, this is chemotherapy competency. And so go to your county hospital and be part of the team that sees cancer patients and assists with chemotherapy. And then we will be coming routinely on a weekly basis, but then we spread it out every 2 weeks once they start getting it every month. Unfortunately, what happens is that because of the paucity of capacity within those hospitals, you find the nurse you've trained and you've been working with over the last 1 year in oncology has actually been sent to orthopedics. And the next time you go there, you ask, where is Jane? They say, oh, Jane now is in the delivery room and she's off today. Or sometimes you train 2 nurses for screening and you find those nurses are absent. One is on maternity leave and the other one, the child was sick. And so any person coming to that hospital during that day or that week or that month will be told, there is no screening for you, come the following month. Mm-hmm. And, this actually really disrupts the kind of care that is being given at that local level. So what International Cancer Institute has done, not only do we offer the trainings, but we've created a mentorship support program where we are supporting these people and mentoring them routinely. So every week we have 2 sessions with each of the trainees and we conduct impact assessments on an annual basis to look at, does this training really affect the outcomes on the ground? Because it's not just telling them, hey, here is a phone, because you can actually tell the government, can you buy these phones? And then we put our telemedicine app. Right now we have an app called, we are using joint platform, ALM, where you can actually get images, including CT scans. It's very interesting that in some of the centers, they can have a technician who does a CT or an X-ray, but they don't have the radiologist who reads that. Mm-hmm. And unfortunately, radiologist probably comes once every 2 weeks. Now you'll have all these people that are for staging or diagnostics or whatever else that needs to be done, who have actually done their part and they already have the imaging, but nobody to read it. So what we said is that we can actually connect with our smartphones and these images via Diacon can be uploaded and we can see it, some of us within the system, and can read and say, we can see a mass here, we can see this, and this is stage XYZ. It actually stops the patient from going back and forth to the hospital and getting all these delays in terms of their diagnostics and treatment. So I really like the idea that when you train, let's not just train and capacity build for the sake of doing it and say, we have trained 80 nurses in this location. The question becomes is that, are those 80 nurses actually functional? What are they really doing in patient care access? Are we following them up and having a mentorship program where even teams are going on the ground and reviewing their training and saying, is there something else we can do to improve your skills? And it's an ongoing process. So I really like the idea that we should not just focus on, and one of the other things in training is not just to focus on the IT teams and nurses. It actually includes the entire spectrum. And for leadership, you have to actually train them on the importance of some of these trainings, especially digital technology. Mm-hmm. Because if the leadership does not understand it, we can talk about it all our lives, but we'll not really have an uptake in those communities. So I'm looking at the training, looking at it from the capacity itself, add skills to it, do mentoring and supportive services, as well as supervision of the training to ensure that people who are not skilled at a certain level are not performing services at those levels they are not skilled for, which is very, very important. Sometimes you train a nurse on one thing like biopsy, and you find the nurse is also giving chemotherapy or advising people on how to treat breast cancer when they are not trained for it. So we have to have that supervision and mentorship. So all around, if we look at the training, all those components are important, and looking at the IT departments to be part of these trainings is very essential.
Okay, well, let's bring in Ray again, because so the panelists are all talking about the need to improve global capacity and accessibility, particularly in low and middle income countries. Ray, how do we do that?
So it's great. I'm really enjoying this discussion, but I think we've got to make sure we're not confusing several things. What my point was, the patient. So the person at the end of the phone, right, or whatever device, you know, how can they get information that will make them more aware of cancer? Early detection. When should I go and see if I have cancer, or these could be early signs? So that is one thing. What the panelists have been saying, which is extremely important, is they're talking about the training that is required for the healthcare professionals. And that's a different subject. And I think, you know, in that subject, I fully agree. We have to see, where does the digital tools and how can they be used to help those care workers? I think we've seen many examples where sometimes a hospital will develop a system and roll out some kind of, you know, technology with devices that is really not suited or tailored to the healthcare professionals in the front lines in any hospital. And I think, you know, many of these things need to be developed kind of ground up, so you get cultural buy-in, and these tools are more developed to help empower the healthcare worker in the jobs they are doing. Then, you know, kind of going backwards and trying to force them to understand something. I think the good
point that Chite made about the fact that even though people in rural areas in sub-Saharan Africa have phones, they often can't use them to the best of their performance, because they don't have enough network to get a video, for example. So who is the onus on to try and improve that?
So okay, well, to try to improve networks is something that I think should be priority number one for any country. And you know, it does take time. If you look at the electrification of the United States or Europe, for example, during the 1800s, early 1900s, it took minimum 50 years. So, you know, to ensure everyone has, you know, internet speeds to see videos, well, you know, that's going to take time. Where, you know, and how they get information is then the models you'll want to use. So you'll want to roll it into how they're culturally getting information. And I really like what I think it was Chita who said that you know, the hub and spoke model seems to be working quite well. So, you know, you can actually focus maybe in a hub, maybe in a center in the village where they can see, you know, information, and it should be made in a way that's very easy to interact with. The good news is that technology interfaces are becoming more and more intuitive. So when we heard the representative Michael from Roche about his mother, you know, in the near future, most likely it'll be, you know, some screen that will talk to his mother, and you know, it will say, you should take this pill today, or don't forget, tomorrow, you know, you have to see Dr. Roberts. You know, so I think these type of things, you know, are super easy to do, and they'll be rolled out more and more to try and make sure that we get those who are being digitally excluded more included. But I think the question you're raising, Sal, it's a tough one. Yeah. It's going to be very, very hard in the very remote areas on this planet to make sure they get the same level of technology and interaction that, you know, we experience here. And I think videos and broadband and that type of thing will improve. One last point, though, where we may see something is as more and more, and I think we'll solve this. I think we'll solve this in about 5 or 10 years, where there'll be rollout of hot air balloons or low flying planes using solar power, or low orbit satellites that are providing internet across the globe. I think over the course of the next 10, 15 years, this will be a thing of the past.
Brilliant. And Michael, obviously your mother is now being held up as the gold standard for understanding digital.
I will let her know. She will be very proud of it. Thank you.
I'm sure she'll be thrilled. But there's been a couple of comments about how the private sector, pardon me for popping, the private sector should get involved in doing more to improve accessibility. So what are the kinds of things that we can do to improve access to digital technologies?
So I think one area we are doing, and let's face it, so we are a research and development company. So our core competency is really research and development. But what we're doing in parallel with partners like ECHO is, I think we have a role to play when it comes to being an incubator, for us, because I think the biggest issue we're also facing is this: a lot of technologies out there, but which of those technologies is truly scalable? And which one can you rapidly sort of like expand into other? And this is like where we really think have to play a role. I'm not only talking about our company, generally as the private sectors. How can we help earlier identify the solutions that are really working and help with the scalability of those solutions? And probably another area would be in this element of digital literacy when it comes to education of frontline healthcare workers, but also of patients. Because I think like we still are the ones in the private sector, we have people on the ground who could support those initiatives.
Yeah, excellent. And let me come to Svetlana, because again, on this issue of telemedicine, Svetlana, I know the WHO has done some research into this. What is the WHO saying are the main barriers to accessing digital technologies?
Thank you, Shule. Really, it is very interesting discussion, and it is underlining a lot of interesting points that I really previously said, that the most important is education. The education of the patients, the education of the health workers, and that is why we have to focus on the how we can do it from the view of the WHO. And we have gotten a survey, and where it showed that the most biggest problem in the countries is not the law or some kind of inter-country things that could give the problem with the technologies. I'm thinking about the such as the private data issues or something like this. But the biggest problem in the countries that showed under the survey of the WHO is to shown that it is the lack of technologies. And that is why we should work very closely with the different sectors, such as the private sector, such as the insurance companies, such as the private sector medical companies, that could provide us this kind of instruments. And one of the example of our successful work that we are doing now, we are working now to produce the tool for the countries, for the member states, how the member states should involve their activities with the private sector. And this is the new tool that will be presented very soon to the member states. And they will give us the opportunity how we could engage with the member states. Of course, they will be adopted to the country needs, to the legislation of the country, to the law of the country, but it will give us the common understanding how the countries could speak with the private sector on the NCD-related issues and mental health.
Thank you. I mean, of course, the priority right now is to try and row back on the gaps that have developed because of the impact of the pandemic on cancer care. But let's also talk about how digital innovation can help build resilience into health systems in the future. And I know, Sanjeev, when I was speaking to you before the panel, you were talking about how transformative digital technology could be. How do you think digital innovation can bring cancer care into the future?
Yeah, I think that, so one of the things that if one attends this whole meeting so far, the overriding issue has been equity. We're talking about digital, we're talking about technology, but for what purpose? I think the primary purpose we're trying to achieve here is equity. Now, certainly things like putting broadband everywhere, giving enough medicines to everybody, giving enough money to low-income countries so they become rich income countries. I mean, that sounds theoretically really amazing, but the challenge is, you know, sharing material resources is still a zero-sum game. Surely, if I gave you half my money today, which I don't plan to, I would only be left with half. So at least at ECHO, our thesis is currently there is enough technology that we could start to build this sharing economy, which is necessary for equity. Equity is necessary for us to have a peaceful, joyful world without wars, etc. That knowledge sharing and democratization of expert knowledge can be done today. And it's not a zero-sum game. I can share my knowledge with you. I can share it with 40 other doctors. I was in New Mexico, and the challenge I was trying to face was there were 28,000 hepatitis C patients, and only 1,500 had been treated. I anticipated 6,000 or 7,000 would die. I'm a gastroenterologist. There was an 8-month wait to see me. I said, how do I tackle this problem? And I said, I need to multiply myself. And so I created 21 new primary care sites. And I said, okay, here's my protocol. They said, no, this is too dangerous. I said, if you joined me every week for a couple of hours, like was mentioned with the nurses in Kenya, once a week, you present cases to each other and to me. And they did that. And within a year, they became experts. And the wait in my clinic fell from 8 months to 2 weeks. And over the next few years, we treated 15,000 patients with a chemotherapy-like regimen through this mentoring. The point I'm saying is, you want to bring equity, the best place to start today is to democratize our knowledge. And I was richer for it because we put in place an all teach, all learn framework that I taught them what I knew, but they taught me what they knew, which was the cultural, economic barriers to implementation. And that's a good starting point. And I can assure you there is no barrier in technology to that.
Yeah.
Because there's enough bandwidth in hospitals, even in Africa, or in where we can have these communities of practice. The other issue is recruitment and retention and producing joy of work for them. When you build these communities of practice, you reduce isolation, you improve satisfaction, you increase self-efficacy, and that creates a more stable, mentored workforce. So that's my thesis.
I think that sharing of education and sharing of training is a really beautiful thing. And one of the things that, you know, technologies is going to help us do more of in the future. Ray, what do you think? What are the things that are going to make a difference? Talk to me about health data, for example. What are we using now? What can we use that is going to transform healthcare, particularly cancer care, in the future?
Well, I think first of all, I think what everyone has said on the panel, I fully agree with. You know, the example that Sanjeev has said, that just sounds right. So, you know, this is not a discussion of A or B. I think the view is, how can these technologies, do what you said? So I think what we can expect, and most likely, obviously, it's going to hopefully cascade as it develops, you know, in the US, most likely in Europe, Asian countries, and then, you know, scale out like the telephone did rapidly, so it can be used by mostly everybody. But I think what we will see is there's still many barriers and issues to get, you know, that data in, you know, the right form to be used for AI technologies. There's, I think, 30% of the world's stored data is just health data, and most of it is not being used. But if that can change, and there's efforts to do that, then we will see some pretty interesting stuff around the corner. There's many of our members that are looking at how can you duplicate virtually what is called a digital twin human organs. And when you do that, you can accelerate the understanding, the research, the treatment, pre-care to see, how can you then roll it out with very minimal error and to increase effectiveness. It will allow, surgeons, for example, to operate if they can know what they're getting into before they even start. So, that type of digital twin technology, I think, is going to be hopefully, in the next decade.
You read about some things which just really do seem like science fiction, like the advent of 5G is going to allow doctors to perform surgeries virtually in real time using robotics on the other side of the world. And artificial intelligence is going to operate, and in fact is even now being used in robot nurses who can provide help in terms of taking blood pressure and advising medication doses and things like that. There are some really, truly exciting developments on the horizon, aren't there?
Well, huge developments. And one thing that I really like is I was on another cancer panel, and there was an executive at Intel who had a stage 4 cancer, and he actually forced that his whole genomic framework was completely digitally analyzed. With that, he started getting precision medicine treatment, and his cancer has gone into complete remission. Now, that is something that in the near future, again, I don't know how long it'll take, hopefully within this decade, it will become more affordable, more scalable. There'll be laws so that insurances can, companies can cover it, and it'll be more accessible to patients, hopefully around the world. And that I know will take time as, in other countries, but, this will advance the treatment where each of your cells are getting the right amount of medicine it needs. It will make a difference.
Yeah.
So I think precision medicine, digital twinning, I can go on actually for an hour, but I know we're running out of time.
Because that's something that Roche and pharma companies have been looking at very intensely. The precision medicine and using digital technologies to really tailor cancer treatments for patients.
Yeah, but I really need to build on what Ray said. It's not science fiction, it's reality, but it's reality in a specific subset for countries. It's not reality for everyone who needs it. And what is a problem is, for example, that I think you, Ray, said like the amount of data we are not using. I would frame it slightly differently, the amount of data we are not allowed to use. So there is a problem when it comes to genomic sequencing, is about where does the data sit? Can you transport it from one country to another? And even if I'm a patient, I would allow you to do that. Even that, sometimes there are law and regulations in place. So I think when it comes to the next wave of digitals, just the digital legislation that has been in place, that was probably developed before Spotify was a thing. So I think there is a next wave of technology coming where just the framework is also not prepared. So when it comes to what needs to be happened to use all the beautiful things that digital twins around it, it's probably also a more robust dialogue about what's the legal framework we need to put in place, particularly.
And that's another interesting facet, government regulations when it comes to things like this. I'm going to ask one more question to Svetlana online, and then I'm going to open the floor up for questions. So do remember, if you do have questions in the audience, the microphones are dotted around, and if you're online, please ask your questions in the Q&A box, and they, through digital technology, pop up on my little screen here, so I can then ask those questions. And if you know who you're going to address a question to, please just say their name. They are ready and eager for your questions. Svetlana, just on this issue on strengthening systems in the future, what is the WHO's approach to building resiliency in systems for all non-communicable diseases and cancer care in the future?
Thank you, Shelley. Really, to finalize this discussion, I should mention that this is 10 years that we are now celebrating from the adopting the first declaration, which was adopted by the member states under the UN General Assembly on the NCDs. And this is the year of our commemoration of this very important political document, where we started focusing on NCDs and where we focused that only the head of states with the multi-stakeholder involvement could solve the problems of NCDs and mental health. And of course, the several documents, the several events were happened after that. And you remember yourself and myself how we did a very big conference 2 years ago in Oman to see how the countries could support the achievement of SDG 3.4 on NCDs. And we discussed it in person. We have a very interesting interactive discussion. We have young people, researchers, civil society, academia, all of us were discussing it. And we are now focusing on the special tools and instruments, how we could develop this agenda. And one of these agenda and one of the instruments which was prepared by WHO is the WHO strategy. It was adopted 2 years ago, and it is the strategy on the digital health. We are now looking on the implementation of this digital health. And it is very important how the countries will do this accordingly to their national legislation, national instruments. And there are other technologies and strategies that we have under the WHO that we could be supported this kind of a very important issue of the reducing the burden of NCDs and especially in cancer. And that is where we are working on. The new thing that we just established under the WHO, it is the Multi-Donors Trust Fund, which the WHO established with the 2 other UN agencies, UNDP and UNICEF. And this is the fund that could raise the funds to reduce the burden of NCDs. We are just working on it, and we have some already partners who are going to give us this financiation to reduce the burden of NCDs. This is one of the instruments how we can invest financially into the countries to reduce the burden of NCDs and especially in cancer. Over.
Thank you, Svetlana. I think we've had some really great cross-section of comments and an exploration of some of the issues at the moment. I wonder if there are any questions from the audience at this point. Would you like to ask our panelists anything about digital technology and health? Let's have a show of hands. How many use fitness trackers? Who's using fitness tracker right now? Getting your steps in. Excellent. How many of you would be happy to see a robot powered by artificial intelligence who would take your blood pressure, for example? Excellent. How many of you are excited by digital technology changing the way we get our healthcare? One of the focuses is self-care, looking after yourself and being able to make decisions about your own health and preventative measures and things like that. How many are excited by that? You see, so people are really excited by what can be done, but I guess the question is how many of us are going to be able to use it, and it's a very different situation obviously in developed countries compared to developing countries. If anyone does have any questions, just put your yes, if you just want to come down to this microphone. Sure. Thank you.
Yeah, hello everybody. Liu Chunchao, my name. I work closely in healthcare between Europe and China. So because of COVID, we not only see, the original virus and how different approaches between the rest of the world and China. and somehow people say, okay, China has successfully, or at least on the first surface, combated the virus. And it has to do with, of course, the policy and governmental system. So, and I think this comes to the point about the data, how you collect data, how you use data, how you track people, right? Sometimes it's unimaginable in Western democracies. But how do you see, like, where is the collective interest to save lives and individual rights when it comes to data privacy issue? Because everything, I don't want to share, I want to give that to the government. How do you see that, and how do we both cope with that issue? Not give up the freedom, not give up the the individual rights, but also say, hey, now is the time for collective interest. Now we have to stand together. Thank you.
That's a really interesting question. So this is about the collection of health data and how we share it securely, and if we can share it, because obviously there are lots of regulations in place about this. Michael, do you want to say something about that?
So I would like to answer that as Michael. I think there's one point which is not negotiable. The patient is the owner of his or her data. And what I would propose is, because that's probably not happening to the amount, is that you need to start a dialogue, because I think there's a lot of myths out there, what's going to happen with the data around it. People sharing freely on Instagram or on Facebook, or doing some of those, fancy questionnaires, tons of data around it. And I think we need to have this more robust dialogue around it, which like civil society, governments around that, because we are operating a lot with patient organizations, and actually a lot of them are way more progressive than we think. It's like, I want to share, but I don't think that the dialogue is currently happening at the level, where it needs to take place.
Ray, can I bring you in? How does technology help with sharing data? I don't want to get too technical, because I know there are things like blockchain where you can securely transmit data and it can't be tampered with. But can digital innovation help with this issue of the need to share data to improve our healthcare, but also at the same time, you have to protect people's privacies?
Yeah, I think I've been waiting for this question. So my answer is, we have to look at it in two different ways. So and it goes back to my previous point. There is the data for the patient, the health records, and then there's data for research. So when we look at the health record, Michael is spot on. It is the patient will own that data. When you look at Europe, and I also want to bust a myth that the GDPR and the data protection rules in Europe prevent people from doing research, prevent member states from sharing data. That's not true. If you look at the GDPR, the whole reason it was created was that people's sensitive personal data would flow across Europe and not be blocked by any member state. European countries have got around the GDPR, finding holes and clauses within it that was negotiated and embedded into it to create their national rules to fragment the flow of data. This has to change, and this is not just happening. So I'm not talking for research purposes, but also for health records. It is very hard for patients, even though it is now a European's inalienable right with the GDPR to own their health records. So they just can't move it from one member state to another because of many of these different rules. You now expand that globally to across the planet, and that situation gets a lot worse. And when during the whole COVID crisis, in previous panels today, even member states didn't want to share the right data that was needed for COVID. They were just sharing process information or kind of what they had to. So some kind of global convention needs to be put into place that has mechanisms where the people will have trust, not only knowing how that data is being used. So when you ask the question to your audience, every hand went up. They've done studies. 83% of people are more than happy for their health records to be used, to solve cancer or to solve an NCD, but they want to know how it's being used. So that level of trust has to be put into place The cybersecurity rules have to, be there. Standards so data is interoperable and shared across member states. And yes, kind of forcing member states to share is also needed. So some sort of, convention has to be put in there. It's not a question of technology, because the technologies, as I said, they definitely exist. You want to talk about blockchain and using distributed ledger technologies, it allows transparency. So you will be able to see very visibly, and you can't change it because it is, as I said, distributed. When something was being done, you can use blockchain technology to make sure that, this COVID passport that I have is accurate. It will show very clearly. I can't fake it. I can't hack it. Maybe in 10 years when we have quantum computing, we can try. But for the moment, if you put something in distributed ledger, it's there for eternity and it's visible. So you have to then see, okay, how do we use these technologies, right? But the technologies definitely are here.
So the technologies are there, but obviously we need a dialogue. Go ahead, Sanjeev.
I think the question that was asked addresses even a deeper level than just technology, I think. And I think that, I'm a physician. I've been practicing in the United States for more than 30 years. And I can say one thing. After all the vaccines were discovered, right, and made highly effective vaccines, even today, only about 77% of the US population has accepted the vaccine. And when I see a patient come into the hospital today who dies, and I've seen that many, many times already, who dies because they didn't take the vaccine, it's extraordinarily painful for me. And so what you said was, how do you bring this balance between public good and individual choice? This doesn't really have so much to do with medicine or COVID-19. It has to do with history and culture. And I can tell you that when I talk to people, even who took the vaccine, the 77% who did, if asked, do you want the government to force you to do this? The answer is almost uniformly no. So that balance has so much to do with who people are, how they see themselves, how they see their relationship with the government, than.
But is it also a government
disease.
problem? Shouldn't the government be instilling more trust in what they're trying to do?
Yes, and I think that, so what we saw here, Julie, is that all this social media and this enormous media where you gave the New York Times publication rights to every citizen, that they could publish their own New York Times on a daily basis, we thought of it as, yes, it's wonderful to connect to my daughter, and it's wonderful to connect to my friends, but we didn't really fully capture what the downside of this kind of enormous right that someone gets with social media to broadcast his views to every citizen. What is all the implications of that? And I think that we need to, over time, come to grips with that question. But yes, it all has to do with trust, but there is more than that.
Yeah.
If you talk to the average American citizen about the right to own a gun, I grew up in India, and I'm saying, why does somebody need an AK-47 lying in his backyard or in his closet? But, the right to defend yourself is sacrosanct in the American Constitution. Yeah. And so I think it goes back to culture and democracy and freedom, rather than just technology or just trust.
Okay, let's bring it back to cancer care. Two gentlemen here. Yes, please find a microphone.
Thank you very much. My name is Stefan German, Fondation Botnar. Fascinating. And I was just moderating before a session on human rights and AI and digital health. And I think what you mentioned, Sanjeev, is sort of really what came in from that side as well, that health is all about trust. And I think we are facing at the moment really a situation that, and that's what Ray mentioned, that we really might need an international regulatory frame, like a framework convention on digital health, data, governance, etc. And I think it's because there are currently big corporations, and we know Facebook was recently just again, that are basically having a business model that's addiction-based. And in the panel, we talked about this is a bit like the tobacco moment at the moment. And I think, and it would be interesting to hear from Michael, and I think he would agree with me, that at the moment, there are some corporate citizens who really need to get their acts together, because they're actually undermining all those other corporations who really have solid, trusted business models, and specifically in health. In the end of the day, health data is about people. We are made up of data. So if we talk about health, data ownership, we talk about people's ownership. And I do think unless we get very quickly, and I really applaud, Ray from Digital Europe to really call, we do need some international framework agreements that really tackle some of these issues to lay a good foundation of which we can build moving forward. Thank you.
Thank you. Thank you very much. Can I just ask you, Chise, just on that subject of trust and governments talking and engaging in dialogue about sharing health tech, what is the attitude of governments in lower income countries, in African countries, for example? Are they taking a lead in this kind of thing?
So for some countries, yes. Like in Kenya, for our data, we have a Data Protection Act of 2019 that is governing the sharing of data. And even we are able to do some clinical trials and share some of our data and even pathology slides and all that with various centers around the world because of that. However, one of the things I've realized in trust is not only the trust that the community has in their governments, but the trust that is created in the healthcare system as a system in general. And so quite often, a lot of interventions are brought as bottoms-up kind of interventions. And therefore, when you have the healthcare professionals distrusting that intervention in the first place, and when patients come to your center, they are looking at you for advice. Like, for instance, a lot of my patients said, we went and got vaccinated because we saw you posted on Facebook that you had received the vaccine. And so sometimes they are looking at who within their system, who's been working with them for long. And if you look at NCDs, our patients, I usually tell them, you are my patient for life. I'll either die fast or you die fast. And so we have a relationship that goes beyond treating and you go. So I keep seeing them over 10 years, 20 years. So I think trust is very, very important, especially in healthcare, because it's really affecting this person's decision-making. And oftentimes we give conflicting information, for instance, especially like, for instance, last year, when we didn't know so much about COVID and there was so much coming in, we also, as healthcare professionals, we didn't know sometimes what to tell patients when they ask us. So I think for when patients trust you and they trust the system, and involving the government in these systems as you create even the digital solutions is very important. I really like what Ray said about having digital solutions to be embraced by patients. One of the ways I look at it is that when you are creating something, before even as you create it, let the governments and the stakeholders have their opinion and inputs and recommendations into this so that the uptake will be much, much higher. For those things that where we've given consistent information like HPV, we are seeing a lot of good uptake in our systems. Okay. So I think even when we talk about we are developing some digital solutions for patients, make sure that there is a lot of buy-in from the healthcare professionals, but also from the governments themselves and the leadership. Thank you.
Thank you, Chise. There was a gentleman here who had a question. Yeah. Thank you.
Yeah, my name is Said. I work for the UN Agency for Palestine Refugees. And my question is the digital divide and the inequality. And I think we do have the NCD patient cancer, but how we can make sure that we will not repeat the same thing we saw in the COVID vaccines. Wonderful breakthrough, wonderful digital breakthrough, end up with the inequality or amplification. So how do you think that we should avoid in the NCD or cancer care for the digital divide or inequality?
Thank you. Thank you very much. Well, Svetlana, maybe this is one that you can answer. How do we try and reduce the inequalities when it comes to treating and preventing NCDs and cancer?
Yeah, thank you very much for this question. Really very timely, and it is showing that it is where we are. As you know, we have the this partnership that we are working is it is the Secretariat of the UN Interagency Task Force as a part of the department that I am leading. We are working with the more than 40 UN agencies, and we are focusing on the NCD-related issues and mental health. And we have the common agenda for these all UN agencies. We see how we can manage it to achieve the SDGs 3.4 on the NCDs and mental health. And that is where we are focusing on. And we are also one of the priority of the UN task force is the providing different capacity building instruments, such as the new, trainings on the lessons learned on NCDs, resource mobilization, future health technologies. And that is where we can see our common interest with the other UN agencies, where we can see that we can be helpful for the member states, for the countries in our efforts to achieving these global goals. Of course, it is, from my perspective, it is something that we are speaking about something very global and as it is, but in the fact, we have the concrete instruments that is investment case that we did already in more than 30 countries globally to show how their countries can use these investment cases to reduce the burden of NCDs in the countries with involving different stakeholders, with the different UN agencies, to see how it is economically useful for the countries to invest into the NCDs and how the government should make their measures and the advocacy to reduce this burden. So this is the way how we are working on. And we already had these investment cases on NCDs, on mental health. We are producing new one on the taxation, on the reduction of the tobacco burden. So there are different ways how we can collaborate with the different UN agencies, where the WHO is leading this process and making the tool that could be useful for the other member states.
Thank you, Svetlana. Okay, well, I know I'm very conscious of the time. I want to take another question from the floor if there is one. I can't see at the back. Is anyone putting their hands up? No? Okay. I did want to ask one question, because just building on what Svetlana was saying, and maybe Sanjeev, I can ask you, just in terms of which sectors need to get involved? What kind of collaboration and partnerships do we need to see to build on the technical advances we've seen during the pandemic?
I think one of the, at least in terms of technology, etc., one of the and data that we are talking about, interoperability, one of the challenges I do see as that the problem is trying to be solved at a national level. But if you really want data interoperability and artificial intelligence and all of these things to come into play, I think you need a non-national body like the World Health Organization to actually create, which of course means if equity is your primary goal, which I believe should be, then some power has to move from national levels to a higher level to create some rules of engagement, rules of equity, rules for sharing when a new vaccine is developed, etc. There would be some need for different rules and regulations to allow.
Okay.
Otherwise, it's very difficult when each country is looking for just their own primary interest, and that leads to inequity in many distribution. And that
comes back to our sharing of information, and
it comes back to the fact that what do we want? What we want is definitely to take care of ourselves first, second, and third. Then we operate a system where we operate just as nations. But if we want equity, we have to operate in a slightly different framework.
Less nationalistic.
Yeah.
Okay, right. We are in the last few minutes. So what I'm going to do is a very quick fire round. Each of my panelists, you've literally got 30 seconds, and I'm very serious about this. 30 seconds, and we're going to talk about, the question is this: what one action needs to be taken, or one challenge that needs to be addressed to improve how digital solutions are used for cancer care? Svetlana, let me start with you. 30 seconds, go.
Thank you. Very, very happy to discuss during this panel discussion. Thanks for all the intervention for the panelists. To my mind, the most important point from my view as a WHO authority, representative of the WHO, is the multi-stakeholders involvement. And we are trying to do this. We are trying to involve the different stakeholders, not only the member states, but also the civil society, academia, and also the private sector to be with us, to provide their inputs, how we can give the countries our impact of the reducing the burden of NCDs. And that is the main point that I want to bring it to you. And thanks very much for all colleagues.
Brilliant. Thank you so much for that. Chite, seconds.
Yes, thank you so much. So I think private-public partnership is really, really important in this case. And for those who think that the digital framework can take very long in sub-Saharan Africa, I tend to disagree. If you look in Kenya, we have M-Pesa, where we can actually send money back and forth just by use of phones. Who knew? We can actually do the same, and we can scale up cancer care so much, and training in sub-Saharan Africa, as well as research. And we've proved that in so many organizations that we've worked with. Make sure you do multi-stakeholder involvement, private-public partnership, but ensure you're involving as many local organizations and patient groups as possible. Thank you.
Chite, thank you very much. Sanjeev, what one action needs to be taken?
You know, the continuum of cancer starts from prevention of cancer, screening of cancer, diagnosis, early treatment. If you can't be successful, survivorship, palliative care. All of these can be made much better if we start with democratizing expert knowledge, which can be done at very low cost. We could implement these best practices at speed, at scale, with higher fidelity, at much lower cost, just by democratizing expert knowledge with a mentoring platform. And that's where I would start.
Sanjeev, thank you very much. Michael?
So I would start with aligning on the outcomes we want to achieve, put partnerships in place to achieve those outcomes, and the third thing is measure the impact.
Thank you, Michael. And Ray?
I think the emergency response that happened for COVID should be the exact same for cancer, and the world should put time and energy to try to solve these things with what the panel said: trust, standards, international data flows, mentoring skills programs. I think that just has to be a must.
Ray, thank you very much indeed. I think we've all been given a lot of food for thought there. I mean, it's clear digital technology may not be a silver bullet, but it's a really good one. And in healthcare scenarios, it allows us to optimize systems, reduce human error, improve patient outcomes. Thank you very much indeed to you, the audience, for your insightful questions. Thank you very much to my speakers. And I think we're all agreed that, Michael, you need to buy your mum a new phone. But thank you very much indeed. That brings the session to a close.
Thank you very much.